طيب والحقيقه السي باب مشكلته الوحيده الريزيستنس بتاع العيانين، ان هو الحقيقه استرابل سم، وابتدوا يعملوا دلوقتي نيزل سي بابس. في شويه نصابين طبعا في الفيسبوك بيعرضوها ودي زي اللتا، لكن في فعلا ديزايند ماشينز او حاجات للنيزل سي باب تبقى مور ايزي للعيان انه يستحملها. مشكله السي باب الماسك الكبير ده يتربط على راسه، واللي بينام على بطنه ولا بتاع مش هيعرف ينام خالص. لكن الحقيقه السي باب changes the life of the patient. He sleeps well, he feels better, والبلاد بريشر بيمبروف.
انا برضو يعني I confirm what you're saying about CPAP. أنا since the discovery إن في something called resistant hypertension, usually I look for this obstruction. يعني usually ask for snoring. يعني every patient coming with me for dyspnea, أنا خلاص one of the questions which we wasn't before إن أنا ask for dyspnea for snoring. وده من ask البارتنرز في ميل أو ميل على فكرة. It's not usually male. في females بس بيبقوا afraid to say إن في snoring. في females كتير. يعني مثلا 2 days ago I have a patient with rheumatic heart disease, mitral stenosis, 55 والvalve area 2 بس بيجي لها paroxysmal nocturnal dyspnea which doesn't favor مع الجريدينت 10. I'm asked for snoring طلعت and then I have a sleep study. She have a paroxysmal obstructive sleep apnea and treated this instead doing mitral valve replacement. فانت you have to ask about any dyspnea أو any hypertension.
هو كانت جت موضة لو تفتكر دكاترة الأنف وأذن كانوا اشتغلوا وابتدوا يعملوا عمليات ويشيلوا حاجات وكل ده طبعا طلع.
لا بس دي مهمة زي ما الدكتور عادل بيقول اللي هي المشكلة البروبلم بتاعة السليب. لا هو في سليب ستادي مش usually in one day in the hospital. يعني في لاب بتعمل سليب ستادي just few hours مثلا في اللاب مش لازم
يعني.
دي 1 وال2 ان هم لازم بيعملوا تيست مثلا يعني not to buy الماشين انها very expensive. يعني تاخد مثلا ب 15,000 20,000 بيقول لك تعمل تيست ان انت responding or not responding.
طيب احنا وصلنا يا دكتور محمد. طيب اتفضلي يا دكتور هناء.
The American Association of Clinical Endocrinologists and the American College of Endocrinology in 2014 settled a new definition of obesity in which obesity can be defined as BMI greater than or equal 30 kilogram per meter square or greater than or equal 25 kilogram per meter square in the presence of one or more obesity-related complication. The WHO recognizes obesity as a global epidemic with highest prevalence in North America and the Middle East area. In Egypt, this is a review about the epidemiology of abdominal obesity done by Professor Mohsen Ibrahim and showed that the prevalence of abdominal obesity in the Egyptian population was about 37.1% for Egyptian men and 50.8% for Egyptian women. Regarding the prevalence of hypertension compared with other WHO regions, Africa has the highest prevalence of hypertension, an overall prevalence of 46% in adults aged 25 years and above. The global burden of the disease attributable to hypertension has significantly increased from the year 2000 to the year 2010 and is predicted to be more and more significantly increased by the year 2025. High blood pressure is called the silent killer, as hypertension is a significant risk factor for the development of all manifestations of cardiovascular disease, including coronary heart disease, stroke, heart failure. Moreover, risk of death from ischemic heart disease or stroke doubles with each increment of 20 millimeter mercury systolic blood pressure or 10 millimeter mercury diastolic blood pressure, in addition to other target organ damage, including cerebrovascular disease or kidney disease as well. The American Medical Association designates obesity as a disease. In fact, obesity poses multiple risks with many adverse clinical consequences, including the risk of hypertension, dyslipidemia, cardiovascular disease, type 2 diabetes mellitus, liver disease, reproductive disorders, cancer risk, and also gastroesophageal reflux disease and psychological diseases. Obesity, particularly central adiposity, is the dominant risk factor for the development of type 2 diabetes mellitus, which routinely clusters with hypertension in what is known as metabolic syndrome, which further amplifies the cardiovascular risk. This is the IDF definition of metabolic syndrome: central obesity or waist circumference more than 94 centimeter in men and more than 80 centimeter in women, plus 2 or more of high triglycerides, low HDL, high blood pressure, and high plasma glucose. What about the relationship between obesity and hypertension? Hypertension is the result of an interaction among genetic, metabolic, and behavioral factors such as obesity, high blood glucose, and other factors. However, the overweight and the obesity are considered the most important significant factors affecting the development of hypertension. In adults, about 75% of the incidence of high blood pressure is directly due to obesity. Results from the Framingham Heart Study showed that 78% of hypertension cases in men and 65% in women can be directly attributed to obesity. 5% weight gain is associated with 20 to 30% increased incidence of hypertension. 10% rise in body weight is associated with approximately 7 millimeter mercury rise in systolic blood pressure. So the prevalence of hypertension increases progressively with increasing body mass index. Not only the presence of obesity per se or the high BMI is the risk factor for hypertension, but also abnormalities in the body fat distribution do play an important role in the development of hypertension, as the central body fat is associated with insulin resistance, dyslipidemia, which are potent determinants of blood pressure elevation than the peripheral body fat. The visceral obesity activates the sympathetic nervous system and the renin-angiotensin-aldosterone system, thus increasing the risk of development of hypertension. This is a very recent study, population-based study done in South Korea, showed that the prevalence of hypertension and the pre-hypertension increase with increasing body mass index, body fat, and waist circumference. This is because the adipocyte is an endocrine organ with many secretory products. Over 50 adipocyte-derived substances have been identified, and many of them have been implicated in the pathogenesis of hypertension. The most important are leptin, insulin, resistin. The hyperleptinemia, hyperinsulinemia, and the insulin resistance are known to activate the sympathetic nervous system. Also, proteins of the renin-angiotensin-aldosterone system, aldosterone-releasing factor, the increase in aldosterone with more salt and water retention, high angiotensin II with more vasoconstriction, all contribute to the development of hypertension, in addition to a secretion of inflammatory cytokines like the tumor necrosis factor alpha, interleukin-6, and C-reactive protein. So the mechanisms by which obesity can induce hypertension can be summarized as the presence of activation of the renin-angiotensin-aldosterone system and the sympathetic nervous system activation. And these mechanisms were confirmed by the Obesity Society and the American Society of Hypertension. Nowadays, we are in the era of COVID-19 pandemic. So what about hypertension and obesity in the time of COVID-19? This is a very recent study that showed that patients with obesity and hypertension are considered vulnerable population with increased risk for COVID-19 infection. Moreover, the presence of obesity and hypertension are known risk factors for having severe illness from COVID-19 and poor outcomes in any age, in persons of any age. Regarding the management of obese hypertensive patient, treatment of obese hypertensive patients should be initiated as early as possible before the development of further complications. This can be achieved through dietary and lifestyle modification, drug therapy, or bariatric surgery. Regarding diet and lifestyle, the DASH diet, with abundance of fresh fruits, vegetables, cereals, and minimizing processed food, meat, and poultry products are known to reduce the blood pressure by 8 to 14 millimeter mercury. The low sodium diet, meta-analysis of randomized trials have shown that an average reducing salt intake to 1.8 gram per day is associated with reduction of 4 millimeter systolic and 2 millimeter diastolic blood pressure. Together, DASH diet with low sodium have more potent, significant effect on reducing blood pressure. Systolic blood pressure can be reduced by nearly 10 millimeter mercury in those with baseline blood pressure, systolic 140 to 149, and can be reduced by more than 20 millimeter mercury in those with baseline systolic blood pressure more than 150. Stopping smoking. Smoking increases blood pressure acutely with an associated rise in arterial stiffness that lasts longer in hypertensive people. Smoking also is known to increase obesity-related disorders and may promote visceral fat accumulation. So there is a good opportunity in lifestyle programs to prevent obesity and hypertension by stopping smoking. Physical exercise, 5% weight loss can result approximately in 2 to 3 millimeter mercury reduction in blood pressure, and blood pressure can be reduced by 5 to 20 millimeter mercury for every 10 kilogram weight loss. Regarding the drug therapy, the best antihypertensive in obese patient is the renin-angiotensin-aldosterone system inhibitor, as it antagonizes the main pathophysiologic mechanism. Endocrine Society Pharmacological Management of Obesity guidelines recommend to avoid the beta blockers, and they prefer ACE inhibitors, ARBs, and calcium channel blockers. Also, the Endocrine Society guidelines can recommend weight loss medications for those with BMI greater than or equal 30 or greater than or equal 27 in the presence of comorbid conditions. Bariatric surgery is currently the most effective treatment modality for morbid obese patients and hypertension-induced obesity. When the bariatric surgery is aimed at treating hypertension or diabetes, it's called the metabolic surgery, not just for weight loss. Bariatric surgery also serves as a practical approach for sustained weight loss, blood pressure control, and the prevention of cardiovascular disease in obese patients with hypertension. The Endocrine Society Clinical Practice Guidelines recommended bariatric surgery for obese patients with BMI greater than or equal 40 or those with BMI greater than or equal 35 kilogram per meter squared in the presence of one or more obesity-related complication. So finally, my take-home message. Obesity and hypertension are major public health problems that contribute to increased morbidity and mortality. Obesity stands out as a major controllable contributor to hypertension. Prevention and early management of obesity before the development of hypertension and other comorbidities have been the goals of preventive efforts. Thank you.
هاي يا دكتورة هنا. حضرتك طبعا you stressed very much upon primary obesity as a cause of hypertension.
Yes.
إنما sometimes the obese hypertensive patient might be due to some other endocrine cause as
Yes.
Cushing syndrome,
Yes.
or secondary to administration of drugs as steroids. And this is sometimes is missed. Particularly, many people nowadays are treated by steroids.
Yes.
This should be considered.
Yes.
This is an important point. Another point, people with bariatric surgery, they claim that whenever they do the surgery, the blood pressure drops down even before losing sufficient weight. Do you believe in that, and how would you explain it?
Actually, the blood pressure should be reduced after weight loss, not before the weight loss, as every 10 kilogram weight loss can reduce the blood pressure by 5 to 20 millimeter mercury. So usually these patients, we see dramatic improvement in blood pressure, blood glucose, and the metabolic profile of the patient after bariatric surgery, starting from 3 months post-bariatric surgery.
Okay, our basic teaching or basic knowledge was that we all tell our patients that every kilo of body weight loss is equal to 1 millimeter mercury reduction. I noticed that you said it's a 10 millimeter or more than 20. Do you believe in this statement that every kilo carries 1 millimeter mercury reduction?
Approximately, this statement is correct, because actually every 5% body weight loss is corresponding to 3 millimeter mercury drop in blood pressure. And there is some small individual differences, but actually 10 kilogram body weight can lead to 5 to 20 millimeter mercury reduction.
Dr. Hani and Dr. Ahmed.
Thank you very much for your lecture. I would like to insist about the metabolic syndrome. It's a very important issue, actually. Do you recommend to begin any treatment when you discover it's a real metabolic syndrome?
Yes, for obese patients, with metabolic syndrome, they should receive, start with metformin. Metformin has the benefit of weight loss and has the benefit of cardiovascular protection and to decrease the insulin resistance. So if the patient is obese and he is pre-diabetic or
Yes,
metabolic syndrome,
pre-diabetic, yes.
yes, pre-diabetic, should receive metformin plus the strict weight loss program. The patient should lose weight. Some patients, when they just only lose weight by the diet programs, they can be totally cured from the blood glucose and the metabolic.
Thank you.
Thank you.
دكتور هناء, it's a great presentation.
Thank you.
سؤالي practical شوي. الcircumference,
I can't.
الابدومينال circumference هو عند الامبلايكس لكن ساعات بيبقى فيه لخبطه في القياس.
من عند الإيليا كراست، من الإيليا كراست
يعني في-
للأوسط.
فانا عايز بس تو ستريس لان ده بيفرق 2 سنتيمتر ممكن
Yes,
يفرقوا صح؟
yes, definitely.
Thank you.
Professor Hanaa, congratulations for your talk. Actually, I'd like to congratulate the board of directors for the selection of topics. Obesity is very much connected to the previous topic of obstructive sleep apnea.
Yes.
In Cairo University, recently we became interested in pericardial fat. And there is a lot of literature about obese patients, more pericardial fat, more diastolic dysfunction, more cardiovascular risk.
Yes.
This is a new era.
Yes.
By magnetic resonance image, we can quantify the amount of fat around the pericardium in obese patients.
Yes.
Professor Mohammed?
دكتورة هناء, thank you very much. في claim على what's known as visceral obesity.
Yes.
وان انت you can do CT to differentiate between two types of obesity the patient. يعني انت obesity is not just the abdominal wall. Sometimes the obesity abdominal wall مفيش hypertension.
Yes.
في واحد thin بس عنده obesity visceral fat.
Yes.
فانت relation of types of fat in relation to hypertension. Which one and how to treat?
Definitely, thank you, Professor Muhammad, for this
defense.
question. This is a very important question. Definitely, the visceral obesity is the metabolically visceral fat is the metabolically active fat. This is the fat which induces inflammation or inflammatory process. We all know that obesity is a state of low-grade inflammatory process or a low grade of inflammatory state. This is due to the visceral fat, which is metabolically active fat that secretes the pro-inflammatory cytokines and secretes the leptin, the resistin, the insulin, and the aldosterone-releasing factors. This is the main mechanism of development of hypertension due to the visceral fat, not the peripheral or the gluteal fat. Sometimes the other types of fat or the gluteal fat is protective, type of protective fat, but the visceral fat is considered the risky type of fat which can induce inflammation and hypertension and metabolic syndrome. Yes.
Dr.
Dr.
Hanaa,
Gamal.
thank you very much for your elegant presentation. There is a debatable issue, and I need your comment, which is the obesity paradox. What's your comment?
I think obesity paradox, this was a term was called for or applied for patients with heart failure, that the patient with low body weight or underweight have poor prognosis. The obesity actually is a risk factor for the development of heart failure. But studies or meta-analysis showed that patients who are not obese have a poor outcome. They are sarcopenic, they are fat depleted, and have poor outcome in heart failure. They are debilitated patients with terminal end-stage heart failure. This is the obesity paradox, that they are not obese, but they have poor outcome. You know, the obesity usually produces the poor outcomes in the target organ damage, or this is the risk factor, but actually the paradox is when the patient is not obese or sarcopenic and depleted from body fat. This is the poor outcome in patients with heart failure. This is the meta-analysis results of studies.
Thank you.
تمام. دكتورة هناء، حضرتك you mentioned a very important point, the effect of COVID-19 infection
Yes.
upon in hypertensive patients.
Yes.
والحقيقة it's very bad. They are at a much greater risk to develop complication and mortality, the hypertensive patients, even if they don't have any other comorbidity.
Yes.
تمام؟ طيب but do you know, or can you tell us the reverse, the effect of COVID-19 infection upon cardiovascular risk factors, including, or in particular, hypertension?
I think I have read some studies, recent studies about the effect of COVID on the care of the patients. Actually, I didn't read in the cardiovascular disease, but the endocrinology in my specialty, that the endocrine diseases or the patient with chronic diseases who caught COVID-19 infection, there was a very poor outcome and the association and the appearance of new comorbidities in the disease. This is the reverse. Actually, those patients are vulnerable and susceptible to COVID-19 infection, and when they catch the COVID-19 infection, they have more poor prognosis for the COVID-19 and for the disease itself and appearance of other comorbid conditions.
في lecture on COVID and cardiovascular risk factors by Enrico Rossi. The third session.
Okay, thank you very much, Dr. Hanaa. We are